Oh, okay. Uh, Good morning, everyone. I'm Dr. Zheng from Taichung Metro Harbour Hospital. Uh, we will present one interesting case, because the case is, we can see soft tissue recurrence and nodal mass, bone mass, and even lung mass in one case. So I think it's a interesting image, and maybe it's, as image that demonstrate or template for further image reading image. And this is a 67 47 years old uh, male, and the diagnosis is prostate cancer diagnosis uh, 2009, 19, and its recent goal is 4+4, and the initial PSA is 161, quite high. And he initially received the bone scan and the and MRI and the CT. Initial presentation, we can see the bone mass and the pelvic lymph node and the lung mass, and uh, both with MRI demonstrated both lobe capsule extension. Also, the patient received the neoadjuvant chemotherapy, and then 2019, and she received sodium fluoride pad. Most of our patients receive our swimming pad uh, will first is receive the sodium fluoride pad. And sodium fluoride pad, we can see the right SI joint and the ischium bone lesion. And then both can also see the same lesion, but it only see the right SI joint lesion. And the patient received in 2020, she received robotic assisted radical prostatectomy. Most of our patients in our hospital receive such kind of surgery. And the pathology shows an invasion, the prostate cancer with both lobe invasion and the bladder neck and the right seminal vesicle and the surgical margin, even surgical margin, malignancy. And we received the first assuming pad. And assuming pad, we can see the PSA level shows initial PSA level is 161. So when receive the hormone therapy, the PSA level come down to 18. And after the operation, the PSA level come to the 0.02. And as times go by, the PSA level PSA level elevated. And we when as it's too late. Sorry, the latest PSM level near the assuming pad before it was 7.6. And so then goes to the next page, see the image. Next. It's a case we can see in the poster bed. Quite FACVC positive avid lesion, lab prostate bed. The SUV max we measure is about 15, quite high. And we can see MI preview to left up image, left up portion of this slide. We can also see there are two hot spots on bilateral upper lung. Okay, next page. Next. Oh, next. Okay, this is the right atrium. You can see on half side and bone lesion, and then and next. Now this is the left iliac node. That nodal we in soft tissue CT soft tissue window of CT, we can see truly two lesion in that pelvic nodal lesion, and the SUV of is about 5.19. And the next, basically we see the lung lesion, left upper lung. But they are vesicoming aviation and it bilateral upper lung. But the point more significant at the left upper lung. The lesion is about we see the SUV is about 12. It's quite FSCB avid. And next, so our report we show our report. We see the FDG aviation in the left post step back. The SUV is about 15, and the left pelvic nodal, and it's true that there are multiple varying size nodule in bilateral lung, and the two of the nodal lesion at the bilateral lung is maybe it's large enough so we can see the FACBC the ability, and we also see the left side several bone lesion in pelvic bone, and also see and also see the physical uptake in thyroid gland, liver, and the pancreas. The patient in our city, we still also see the atherosclerosis, but maybe that's not the key point of this image. Next. Oh, okay. As conclusion, though, the patient stay comparable status with prostatectomy, and it's quite definitely we have a strong confidence about the patient is left post-bed recurrence pelvic nodal and multiple lung and bone metastasis. So the patient will receive salvage treatment. And we like to introduce it because we German in our hospital would like to see our she like to we communication she what they want the nuclear medicine to see to label what the lesion we have confidence about the lesion. So we use the 5-4 grading for all our lesion we see to describe our confidence. So this is our report. Maybe this patient is very differently to see multiple even regional nodal, tissue nodal, and the lung and the bone mass. But I say we propose that this case to see is there even the data user or other expert you see such case is more common in your experience, and that's our question then. Thank you.
Thank you. This is, of course, unfortunate for the patient, but a very illustrative case. You have a little bit of everything here. And there was nothing, that I think you've picked up all the findings and you described them, well. And, occasionally we do, and this patient was very high risk, obviously, right? He presented with a PSA of like 160, right? So, there are a lot of myths, and very often, sometimes we do see patients with lung nodules, even at lower PSAs, actually, and that's been surprising. And bone metastasis. I think as our imaging gets better, we realize we're seeing more distant disease, even at lower PSAs, though, of course, this patient had a rapidly rising PSA. So I think that's part of it is, our radiation oncologists when we're deciding to treat a patient, we'll also talk about how rapid PSA might be rising. So I think that's really excellent. Was this patient on androgen deprivation when he got the fluciclovine?
And the patient is now is receiving television treatment, and we have maybe we will suggest the next assuming path for reference, and
Okay.
the latest PSA level or the latest PSA level in this March is about 0.4. So our image guide a good treatment choice for the clinician, so we can see the PSA level come down.
Okay, that's interesting. So this just brings a general question that people ask me. Should they scan a patient when on androgen deprivation? And I tell them that it depends what's happening, right? If the PSA is going down and they're on androgen deprivation, well, you could ask why get the scan in the first place, but your fluciclovine is going to be more likely to be negative. If the PSA is going up while the patient's on androgen deprivation, they're becoming castration resistant. So then I think we've seen positive fluciclovine, even though the patient's on androgen deprivation. So John, I don't know what your experience is with that, but yeah, I mean, we see patients with these widespread Mets every once in a while. This is a very high risk patient, so.
David, I think we've had limited experience, doing this during therapy. What you described, I think, is the most common scenario where we're imaging because we think they're progressing on systemic therapy.
Right.
We have seen a few cases where there's response almost everywhere, and then there's a lesion that persists. And I don't know what that means yet, but I do think there may be a role. The other thing, which I haven't seen as much for fluciclovine, but there is some data for choline, particularly as you start to get into metastatic castrate resistance, that the imaging actually may be more accurate than the PSA. Where exactly that happens, in the time course, not clear that would apply to a patient in this setting, but there may be especially as they become castrate resistant, the imaging may actually be, substantially more important. I don't know that there's a huge amount of data for fluciclovine in that setting, but I would expect it to be reasonable to, anticipate that it would be like choline.
Right. Yeah, I think there's some maybe preclinical data showing that fluciclovine might be active during all phases of the you may say the continuum from castration from androgen sensitive to resistant, but I think there's a lot less data with humans, and some of the preclinical data suggests that the different LAT transporters become important at different phases of the disease process. So,
I ask that what your experience on end-to-end therapy because we for anti-androgen therapy will upregulate PSMA expression, but it also kills tumor cells. So it's like a conflict. But for Axumi, it should not be like this situation. Thank you.
Yeah, I think Dr. McConaughey and I were talking about that earlier today. I don't think there's been as much study on it, but I think that with androgen deprivation, my anecdotal experience has been that you don't get the flare that you get with PSMA. It'll generally follow what the PSA is, and then as it rises and you become castration resistant, I think you get, more fluciclovine activity. But I think there's not as much experience with patients on this area.
Case sharing for recurrent prostate cancer. I'm Dr. Chao from McCain Memorial Hospital. Next slide. I changed the slide a little bit. So we can see the case 2A. It's an 81 years old prostate cancer patient. Gleason score is 7. B3B N-link and initial PSA is 30. He had received prostatectomy in 2019. And we can see the elevated PSA from 0.04 in April 2020 to 0.42 in September 2020 and 0.53 in December 2020. And the PET-CT was performed in January 2021. And the following PSA is rising to 0.81 in April 2021. And this patient is ready for salvage radiotherapy. Next slide. And we perform PET-CT using Philips digital camera. Next slide. We can see the solid blue arrow in the mid upper panel. We see the local recurrence in the left prostate bed. Because the prostate bed is a very high risk region and high sensitivity because this patient had received prostatectomy. There's a focal area in the bed, and even though SUV maximum is not that high, but we still regard this point, this spot, as a positive for local recurrence. The right upper panel is the coronal view, and the right lower panel is the PET-CT fusion image. In the next slide. We also see the bladder wall uptake is a physiological event in the anterior aspect. Next slide. This patient have a asymmetric inguinal uptake. We regard it as a physiological variant. Why? It's an asymmetric uptake in the inguinal region because the inguinal region is a lower risk region. And the SUV maxima is less than the bone marrow. Just the bone marrow SUV maxima is 4.98. Next slide. We can see the case 2B. The case 2B is a 72 years old prostate cancer patient. Gleason score is 7 and stage 2B. He also received prostatectomy in 2016. We can see the PSA level is elevated from 0.02 to 0.09, 0.29, and PET-CT was performed also in January 2021. And the PSA level is continuously uprising, 0.4. Yeah. The next slide. Next slide. We also see the local, not the midline hotspot. Next to the hotspot, there is a very small, tiny focal lesion in the left prostate bed. Also, prostate bed is a very high risk region and high sensitivity. Although the SV maxima is not that high, it is only 2.32.
we also suspect this spot is a local recurrence. Next slide. And we also see the vesical urethra anastomosis in the mid upper panel, and sagittal view in the right upper panel is also a very high risk region. It's a focal uptake, even though the SUV is also not that high, 2.44. We also regard this lesion as a positive findings. Next slide. This hotspot is in the bladder wall, close to bladder wall. It's easy to misunderstood as a local recurrence. But if we correlate with the CT imaging, it's not in the prostate bed. It's in the bladder wall or in the bladder lumen. So we also have to rule out the bladder tumor, but it's not recurrence. Next slide. And we also see very interesting the periurethra uptake, linear uptake. You can see the right panel, the lower arrow, the linear uptake in the periurethra region. Maybe possible the smooth muscle uptake, but we think it's not urine because no any activity in the bladder. Next slide. And this patient also see a very interesting point. We see the benign lesions in the ganglia, including the bilateral separation in the left panel. And the second panel, we can see also see the celiac region and also bilateral adrenal medulla. Next slide. Thank you. Thank you for Schuster's sharing experience. Thank you.
You're muted, Dr. Schuster.
I think these are, I agree, these are in the bladder lumen and not in the wall. If you have any questions, get an MR. You know, there doesn't look like there's any soft tissue there. It might be reasonable to get an ultrasound. I think there's two issues here. So the first is, you know, why are you doing it, right? And the clinician who's ordering it, you know, first of all, they want to see if there's any distant disease, right? And that as best as you can tell, there's no local, regional, or distant disease. So then, you know, the patient is eligible for salvage radiotherapy. And I think at least, even if you are not definitive and you said, well, you know, those foci are equivocal or, you know, suspicious, they could at least make sure that those are contained within their radiation field. And I think that, you know, that's important. So you don't necessarily have to prove it definitively because they're gonna radiate if you don't have anything distant or there's no, you know, obviously if CC nodes in the pelvis, they're gonna radiate the pelvis. If clinically, you know, the patient was node positive when they, you know, had the original prostatectomy, you have to, you know, radiate the pelvis. But short of that, you know, if the plan is then just to radiate the bed, because that's a default, they could at least make sure that's included. And that's what we did with Empire One. You know, we used those areas, even though some of them were subtle, to make sure that they were contained within the simulation field. And actually in Empire 2, we're boosting to the areas of activity. So we're going one step further, you know, as part of the Empire 2 trial. So I think those are all very good points, and you know, those were nice cases. I don't know if John has anything to add.
No, nothing to add, but just to add on to what you, or nothing different to say, but to add to what you had mentioned, you know, a lot of times for the radiation oncologists, many of these areas are kind of low risk to either include in the plan or even boost. And so I agree, it's important to, you know, bring those to their attention so they can be aware and plan accordingly.
And, you know, the periurethral uptake, I don't know what kind of, I don't know if we could ever prove this. But, you know, I think, you know, talking over with urologists, it's probably smooth muscle, you know, could it be you know, cavernosa, but then there's no other blood pool around, you know, so, you know, smooth muscle's our best guess, you know, short of, I don't know how you'd ever prove it, you know. So that's a good case.
Hello, everyone. Dr. Liu from National Taiwan University Hospital. I'm a nuclear medicine physician. Next slide, please. My case is relatively simple, but it's challenging, at least to me. And he's a 69 years old male with the diagnosis of prostate cancer, fresh case last year, and he has PSA level 7 with Gleason score 9, localized disease by MRI and bone scan. So he chose to join a clinical trial called Proteus, which is enrolling high-risk patients with ADT with or without apalutamide for 6 months, and radical prostatectomy by robotic surgery with extensive lymph node dissection. And after surgery, the patient will receive another 6 months ADT with or without apalutamide. So the patient went through radical P this year. Next slide, please. And the left side bone scan was performed before surgery, which is normal, but after surgery, according to protocol, we performed bone scan, which showed equivocal T lesion on T11 level. Next slide, please. So we have performed MRI, which confirmed that both downstairs and T1 phase set is highly suspicious for metastasis. Next slide, please. And we have compared sequential CT imagings, which showed that T11 lesion was a new lesion after surgery. Next slide, please. And finally, the date was run is conducted like early March, and the T11 lesion showed no obvious vacuum uptake. Next slide. So my question is the etiology of T11 lesion, because we have to figure out if it has a metastasis to quit the protocol or stay in the protocol. Thank you.
Yeah. So, and Bonnie, maybe you can give me the ability to share, because I'd like to show this on the MIM. First of all, bottom line is that's a metastasis. Okay. And if you let me share, Bonnie, I could, here we go. Hold on. Give me 1 second. There we go. Okay. There we go. If you could all see this. So, and so this is the case. And just a couple things just worth pointing out. You know, first of all, you know, it looks like that there is, you know, activity at the anastomosis. And then it's a little more subtle here. I wonder if there is some also spread at the lateral surgical margin. And this patient may be, you know, just like 1 month out from surgery. So it's possible some of that's inflammatory, but that, you know, I really think is disease. And then the other thing that's worth pointing out here is, and this is subtle, but the more of these you see, the more you begin to appreciate it, is that you see back here, I mean, that's a sub-centimeter node, that's a pre-sciatic node, and that looks suspicious to me. That looks very suspicious. You start seeing these nodes, you know, and you don't see one on the other side. So that's suspicious as well. And then I think that, you know, you're right, that this lesion here is new. It's a new sclerosis, clearly, and the patient was on neoadjuvant androgen deprivation. And even though it's photopenic, it's definitely a metastasis that developed. Now, my question is, usually at this level of sclerosis, okay, I've seen at least some fluciclovine activity. So I wonder if this is a partially treated metastasis, and that, when the patient was on neoadjuvant therapy, you started treating this, that's when it became sclerotic, right? Because the patient was on androgen deprivation, and now, you've kind of maybe suppressed the fluciclovine activity on it. The other possibility is that this is just one of these sclerotic lesions that, doesn't have fluciclovine activity. Usually I've seen them with more dense sclerosis. So it's possible a little bit of both could be going on. So I don't know if John has any comment on that.
Yeah, no, I agree. I would wonder if it's either partially or, treated MET.
Yeah.
And I wonder if that's why it became apparent, was because it actually was treated and healing.
And as far as the trial is concerned, if developing, if having a skeletal metastasis precludes you from the trial, that's a skeletal metastasis. There's no doubt about it. Fluciclovine or no uptake. Now, it could be treated by this point, but,
By the way, we checked the PSA level, and it's currently undetectable.
Now it's undetectable. Not now. One of the patients on androgen deprivation, though, right?
Yeah. He has only two PSA level check. One is before surgery, which is around 7, and one is after surgery. During the X-ray PET is undetectable.
Right, but is the patient on androgen deprivation?
He is on Zoladex, but with or without apalutamide.
Right. So, I think that's kind of, once you're on androgen deprivation, like all bets are off, right? So, it's doing its job, right? But the patient definitely had a MET, that got treated. And on the surgery, were there any positive margins or was it negative margins? Oh, can't hear you. I think the microphone is not working. Yeah, microphone.
The margin is negative.
Margins are negative. Okay. But again, I think whatever, the androgen deprivation is doing its job. You have to see what happens when they take him off the androgen deprivation. And he becomes, and his testosterone's restored. Because that's the other thing, right? So not only, it's usually, 3 to 6 months in most men before your testosterone gets restored. And then you actually see if the PSA goes up or not. Sometimes androgen deprivation, I've seen it treat small lesions and they stay dead. But, a lot of times they go up again.
And we can only speculate in this case, but this is a case that would have been very interesting to see what the fluciclovine looked like before the neoadjuvant therapy.
Right.
I suspect we would have seen this with fluciclovine if it had been done at initial staging.
Dr. McConaughey and Dr. Schuster, there is a new question in the Q&A. How to differentiate ganglions or lymph nodes in the iliac region?
So, okay, you just have to know the anatomy. and this is the same thing with PSMA. I think most of the time for the presacral lymph nodes, or, the sacral ganglia, you could trace them out. To the sacral foramina, and they're usually paired. So you just have to look at a lot, and then usually you see them. Most of the time, they're not hot on fluciclovine. Occasionally, like we saw in that case, they are. Most of the time, they're not. But anatomically, you could trace them out. Same thing with the celiac ganglion and the stellate. You just have to know it's in a typical position. And I didn't know anything about these ganglia before I started reading, these kind of PET scans. So, they never taught me that. Well, they probably did in an anatomy class, but I was, maybe doodling or something. And now, I kind of forced myself to go over the old anatomy books and to see there's a lot of ganglia. The ganglia run all the way up in front and like on top of the aorta and behind the aorta. So it's kind of interesting. You just have to be knowledgeable about the anatomy. That's all. John.
No, I think that's right. I think just pausing and thinking, could this be a physiologic structure is key. But in my experience, the only one I routinely see is the celiac ganglion. That's pretty frequent. The others, I think the case that was shown earlier is that in the sacral region was the best one I've seen, or one of the best.
Okay, Dr. Yen, did you want to do a closing or?
Excuse me. Going back to the previous study, for those T11 bone lesion, can we conclude that as the lesion is after therapy, is it a remission from the previous metastatic lesion? Can we say that?
I don't think you could be 100%, like at what point. It's clearly healing, right? It wasn't there before. The patient was put on androgen deprivation, and then it started appearing. So that's like the typical appearance of a healing sclerotic met. Whether there's live cancer cells in it still, that might be up for debate. And this is where having a baseline study, even a baseline MR with diffusion weighting and then seeing what happens on the, so it's just very hard to tell without a baseline study. I think you just need to continue to follow it up.
I agree with David. Maybe if you showed that the bone scan activity resolved, that might give you some confidence that it's truly fully treated. But agreed, only when they, stop therapy or if it progresses will you know for sure.
This is we don't have the fourth case. No. Okay.
No, they.
Okay. So I'm doing the closing. Thank you very much, Dr. Schuster and Dr. McConaughey. And I think we have this very useful and very helpful for us to learn how to interpretation this PET scan for saccharin. And then I think we can, we hope we have more chance. Maybe next time we can learn more from you both. And also thank Dr. Barney and your team. And thank you for your organization. And also thank you for all our colleagues here in person and also online. So final, I wish you a wonderful weekend. Thank you very much. See you.
Thank you very much.
Thank you.
Thank you.
This will now conclude the recording. Thank you.